Hello everyone, welcome back. I hope you're all doing super well. My name is Karan, and today we're going to be talking about head injuries and all types of intracranial bleeds. So starting off, let's talk a bit about increased intracranial pressure because a lot of our head injuries and bleeds come back to this basic concept. So it's good to understand what's going on. So the intracranial pressure, as the name suggests, is the pressure inside in the brain, which usually sits at about 10 millimeters of mercury. Now, there are a few reasons why you can have increase in this ICP. Anything that increases the volume or tries to increase the volume of the content within the skull is going to raise the ICP. So this includes increase in the volume of the CSF called hydrocephalus. You can have intracranial blood volume because of a bleed, like a hematoma, or you can have something going on with the brain tissue itself, infarcts that have caused edema, tumors that are compressive, hypoxic edema as well, infections and inflammation, as well as abscesses. Usually, as you have an increase in the pressure, your brain can compensate for this. But it can only do so until about 25 millimeters of mercury, and then everything kind of hits the fan. We're worried about a few things here. So firstly, the one thing we're worried about is the perfusion to the brain. As you know, blood flow is based on pressures, and it flows from a high pressure area to a low pressure area. If we have an increase in the ICP, this is going to obviously lead to reduction in the blood flow. And we may reach a point where if the intracranial pressure matches the systolic blood pressure, you're going to have absolutely no blood flow or perfusion to the brain. And that's obviously a concern. But way before you reach that point, the other big thing we worry about is herniations. What is a herniation? Now, herniation basically means that as the pressure increases, a part of the brain may slip through and go somewhere it should not be. And there are three broad types of herniation that we talk about. We have a subfalcine herniation, as you can see, it's here. It's supratentorial. We then have a transtentorial. So this is the tentorial membrane. This is a transtentorial, and this is a tonsillar herniation. And the order is also from least severe to most severe in terms of how they present and the complications of them. So this can present with a bursting headache that's made worse with anything that kind of leads you to strain. So coughing, sneezing, straining, all of these can make it worse. You may have neurocognitive symptoms, so confusion, amnesia, and so on. Back pain, which I'm not quite sure why it happens, but happens. And then you can also have a progression to seizures, coma, and eventually death. So with three specific ones, what are we worried about with each? With a subfalcine herniation, because this is within ACA or the anterior cerebral artery territory, we worry that this herniation may put pressure on the ACA and stop its blood flow or cause something called vessel kinking. With the transtentorial herniation, we're not so much worried about the actual tissue that slipped through, but we're worried about what it's compressing on. As you can see, the structures that are going to be in this part of the brainstem are going to be the midbrain and the pons. With compression on the midbrain, you can have a reduced GCS. You can also have something called a Cushing's triad, quite typical of increased intracranial pressure. And this is characterized by an increase in blood pressure, a widening pulse pressure, and a bradycardia. You can also have hyperventilation or something called Cheyne-Stokes respiration. Going back to our lecture on strokes, I hopefully you remember our rule of fours and would know that the third cranial nerve and the sixth cranial nerve are both midline structures in the midbrain and the pons respectively. So as you compress, that can also lead to a nerve compression. You can also have this thing called Duret hemorrhages, which are these small tiny bleeds in the midbrain and the pons because you're compressing upon them. And you can lastly also compress the posterior cerebral artery. So a lot of compressive stuff, right? But the worst one by far are going to be your tonsillar herniations. Because your respiratory centers lie in the medulla, this can lead to intermittent apneas, comas, and death, as well as obstruction of the CSF. And this is by far the worst one to have. Next, you have your blunt force trauma. So this is your typical head injury. Patient came in, hey doc, I hit my head against something. I was in a motor vehicle accident. I was skating, hit a pole. Yeah. So what are we worried about in the acute term? So the first thing we're worried about is something called a cortical contusion. Cortical contusion is quite a complex way of just saying a bruise. So what's happening is, think if your brain is being this smushy jelly inside your skull. If you're, let's say, skating towards something and then you suddenly stop, the skull is stopped, but the brain inside is still going to be kind of moving forward, and you're going to bruise the front part of the brain first. That's called a Coupe injury, Coupe, C-O-U-P. And then as it bounces off, the back part of the brain is going to hit the back part of the skull, and that's called a contrecoupe injury. And you can see what a contusion looks like here on on post-mortem sample. I'm not sure why this patient died, but it doesn't look pretty. Surprisingly enough, I also had a cortical contusion, and that led to a skull fracture at the tender age of 10, after which my academic performance also increased. So I don't know if I should be digging up a linkage there, or I'm not quite sure what happened, but look, we're here and I shall not complain. You can also have lacerations or breaks or tears in the cortical tissue. But the big one we worry about is this thing called diffuse axonal injury. Now, we talked about kind of our linear motions, right? That can cause a coupe and counter-coupe injury. But then often with quick rotational movements, you can have these severe shearing forces that can actually rip axons apart, and you are effectively tearing nerves apart. Now, in the short term and in the acute setting, you often won't see any changes on imaging. You can see obviously some changes on microscopy with these retraction balls of the nerves that are kind of balled up. But I would be surprised if you're doing microscopy on a patient who is alive. You might notice widespread bleeds because of this rotational trauma. Obviously, they would not have a skull fracture because of the rotational force, but most of these patients, 50%, die within 2 weeks. So not the best prognosis. And you may recognize this person as Michael Schumacher, one of the greatest F1 drivers ever. And he had a diffuse axonal injury and is still in a bed stable state, which surprisingly wasn't because of F1. It was while he was skiing in the Alps. I don't know why that was relevant, but moving on. Now, talking about hemorrhaging, we have 4 different types of hemorrhages, and I've gone through this in our lecture on approaching headaches, but I'll talk about this here as well, just for the sake of completeness. Each one of them presents a bit differently, and we need to know the differences in A, how they present, B, why they happen, C, what they look like on a CT, and what are some other interesting tidbits about them. So in terms of mechanism, epidural hemorrhages are mostly due to direct trauma to the lateral calvarium or to the pterion. Subdural hemorrhages, on the other hand, because the subdural space, as I mentioned in the last lecture, carries a lot of bridging veins, it's often the shearing trauma or sudden movements, rotations, or decelerations that lead to shearing of these veins and venous bleeding. Subarachnoid hemorrhages are often due to damages to the cerebral arteries, quite commonly aneurysms that burst. And intraparenchymal hemorrhages are your hemorrhagic strokes, often due to malignant hypertension. Now, epidural hemorrhages are quite acute, and you have a sharp drop in GCS. Subdural hemorrhages are more so chronic. Subarachnoids and intraparenchymal bleeds are both going to be sudden and severe. Some typical Monash buzzwords for situations: kid hit with a cricket ball on the side of his head is going to be an epidural. An alcoholic old person is going to have a subdural. And again, why do old people get subdurals in particular? Well, as I mentioned earlier, as the brain atrophies, it shrinks and pulls on those bridging veins and kind of stretches them even further. And as you can imagine, if the veins are nice and stretched, even the slightest of shearing forces could potentially rupture them and cause a bleed. A subarachnoid, you can have a slight headache for days, and that's often due to something called a sentinel bleed, or like a smaller mini bleed. And then you have a full-blown subarachnoid hemorrhage with a sudden thunderclap headache. Having a history of PCKD, or polycystic kidney disease, is another kind of interesting association, because PCKD is associated with something called berry aneurysms, quite commonly in the anterior communicating and the posterior communicating arteries. It's also associated with cysts in the liver, but that's not really relevant here. Intraparenchymal, as I mentioned, malignant hypertension. You might, and you would see blood in the subarachnoid in LP, because it would spread through the meninges. So when you look at a CT, again, the 5 questions I want you to be asking yourself: A, what is the shape of the bleed? B, is the blood acute or chronic or actively bleeding? C, does it enter the sulci? D, is there a midline shift? And E, is there a skull fracture or associated subcutaneous swelling that you can notice? Now, I will be going through this, and I have gone through this before. So if you've already seen this, feel free to skip ahead. If you haven't, sit tight. Looking at this picture, this seems to be kind of a crescent-like, or not a crescent-like, like a oval. I can't even, it's too late. What's the shape called? So this would be described as a lentiform shape. And as you can see, it appears to be brighter than the surrounding tissue, which is why we call it a hyperdensity. You then ask yourself, is the blood acute or chronic, or is it actively bleeding? Now, typically when blood is bright white, that indicates that it is new blood. And you ask yourself, is it homogeneous or spotty? And this looks pretty homogeneous to me, and that indicates that it's a single bleed that's spread quite rapidly. Does it enter and fill the sulci? No, it doesn't, because we can still see the sulci are present and patent. Is there a midline shift? You look at the ventricles, and yes, you can see that it's shifted to the right. Is there a skull fracture or associated subcutaneous swelling? As you can see, there appears to be a fracture here. And as you can see, this subcutaneous tissue is swollen up as well. And this is an epidural or an extradural hemorrhage. Next, moving on to this other one. Now, unlike this one, which is kind of from here to here, quite distinct, looks like an oval, this is a bit different. Now, this one looks like a crescent. It extends way beyond the other one. It's anterior to almost the posterior hemisphere. Now, again, answering the same questions: is the blood acute, chronic, or actively bleeding? It still appears to be white, but it's a bit spotty, which means it may be a bit more chronic than our earlier picture. Does it enter and fill the sulci? No, we can still see the sulci here, here, here. We can still see the sulci. Is there a midline shift? Yes, quite a significant midline shift. Can you see a skull fracture? Well, I can't, but I'm not a radiologist. So I would say safe, or not a safe, a questionable no. And this is a subdural hemorrhage. And as if you remember, subdural hemorrhages occur because it damaged those bridging veins. And those bridging veins are going to be venous, as the name suggests. So this is going to be full of venous blood. Now, what is this? It's basically the exact same thing, but instead of the blood being white, it's much darker than the surrounding area. So now this is a hypodensity. And the fact that it's darker usually indicates that this might have been a chronic bleed. So this would be a chronic subdural hemorrhage. Lastly, this one just looks weird to me, to be honest. I have no better way of describing it. I cannot understand what it is. It just looks like a starfish from SpongeBob. And when I see this, I get really concerned, because this is a subarachnoid hemorrhage. That would be my only advice for identifying these ones. This is a subarachnoid hemorrhage, probably due to a burst artery or because of an aneurysm. Real bad prognosis, we need to go clip the aneurysm immediately. A common distinction you'll be asked to make would be between subdural and epidural hematomas. Subdural, as the name suggests, because it's subdural, which is where the bridging veins are, it's going to be venous blood. So I think of it as a blue banana, although it doesn't help because bananas aren't blue. So I don't know who came up with that acronym, but blue bananas, 'cause it's venous blood and it's banana shaped. And you have a red lemon. Again, doesn't make sense, but just stay with me. Red lemon because it's lemon shaped or lens shaped or convex, and it's going to be arterial blood. You typically from the middle meningeal artery. Cool. And that's all we had for head injuries and bleeds. I hope that helped. If you have any questions, please feel free to get in touch either on my email or through Facebook. I'm happy to answer any questions you may have. And as always, please look after yourself and please look after your loved ones.